And thank you to ILSI for including me in this symposium. Certainly from my experience at FDA, this is a very important topic in terms of how we improve the quality of research that's used in policy. My disclosure, I do not have grants or research support at this time. I am a member of a committee for the World Health Organization. It's the subcommittee on diet and health. I don't have anything to report in the others. I did report that other financial material was, in fact, being an employee of the Food and Drug Administration, but I am now retired from that. So my understanding of the purpose of my comments, more to sort of kick off the session, is to try and illustrate certain areas of policy in which reliable scientific information is essential. And to do that, to talk about how is science used in decision making and what types of scientific information are most useful. So to do that, I'm going to use three examples where I think illustrate the point very well. One related to nutrition labeling, including both mandatory declaration, nutrient declaration, as well as nutrition-related claims, the development of the Dietary Guidelines for Americans, and also I want to speak to the WHO process that I've been involved with on the development of guidelines and standards that are then used in international forums. So if we go to the first example on nutrition labeling, the result of the Nutrition Labeling and Education Act of 1990 was mandatory nutrient declaration, as well as the provision then for voluntary use of health claims and nutrient content claims. So I'm going to talk about each one of these. So first, the mandatory. If you look at what was done in the early 1990s in order to implement the requirements of NLEA, these are the types of scientific reports that the agency relied on in order to move forward. The Surgeon General's report on nutrition and health, the National Academy report on diet and health, the Dietary Guidelines, the RDAs that are developed by the Institute of Medicine, National Academy of Sciences, and of course the survey data. At that point, it would have been the USDA continuing survey of food intake. But what the agency had to look at was the public health significance of the nutrition information, and at that point the emphasis was on dietary factors related to chronic disease such as cardiovascular disease, cancer, and diabetes, but also considered the adequacy of nutrient intake. Were there nutrients that we were concerned that the public should in fact be getting adequate intake? For anything that was to be declared in nutrition labeling, there was a desire to have a quantitative recommendation and use a reference value so consumers would have a daily value that, to make a judgment about the nutrient level within the food product. And again, because of the way the law was structured, FDA needed to know the amount of the food that is customarily consumed so it could define the serving size. There's often a lot of confusion about serving size, but the law says it has to be the amount customarily consumed. So survey data is critically important for that information. FDA has been undergoing the process of updating nutrition facts. I think we all hope it happens in our lifetime. And there are several key references that are important for that update. Certainly the Dietary Reference Reports and any related IOM reports from the National Academy of Sciences, any other relevant authoritative statements, such as statements that NIH might make that is an authoritative statement, and NHANES information on nutrient intake and food consumption patterns, because it is looking at serving size as a part of that update. The Dietary Guidelines for Americans, 2010 are the current ones, but the process, when the process began, it was the Dietary Guidelines from 2005. And of course, any other relevant scientific literature. And it evaluates very carefully the scientific literature and whether it has a credible report that it can rely on. So that's for the mandatory side of nutrition labeling. And to a certain extent, FDA had the advantage there that the law said you're going to do it. They just have to come up with references that gave them the appropriate public health context of what to declare and how to declare it. The other side is more of an ongoing process, and this is the use of voluntary claims. And I'm going to spend most of my time talking about health claims, but I do want to just note that for nutrient content claims, there are two types of information that are especially important. One is having the reference value, so the dietary reference intakes, the process that the IOM goes through, is critically important to get those reference values, and also analytical methods. So any research that focuses on accurate analytical methods for those nutrients becomes a very important part of making sure those nutrient content claims are accurate and useful to consumers. But I'm going to go on and talk more about health claims. So just to remind you of the health claims, that they allow a food, including dietary supplements, to bear a science-backed claim about reducing risk of food. They are based on a particular substance and a disease, and they are about reducing risk. They are not about treating, mitigating, preventing, or curing disease. Those would be drug claims. And FDA has to go through a process to allow a health claim to be used in food labeling. In looking at that, FDA, from the very beginning, FDA recognized that there was a continuum of scientific evidence, and the law itself focused on the significant scientific agreement, that these are the claims that FDA should authorize, and that's a body of consistent, relevant evidence from well-designed clinical and/or epidemiological evidence. FDA, of course, then has to figure out what is relevant, well-designed studies. Because of several court cases challenging FDA's denial of certain claims on a First Amendment basis, a freedom of speech basis, FDA also has qualified health claims which are based on emerging evidence. And the review of the science is the same, whether it's a qualified health claim or what's referred to as an SSA claim. It's just at the end you decide where's the level of evidence. So this schematic is to show the process, the overall process, that FDA begins with all the data, and I'm going to talk about each of these steps. And because of the nature of this symposium, I really want to emphasize it's how do we get down to this point? Is there a credible body of evidence to look at for the claim? We're not going to really talk much about the end result then going through actually creating the claim. So this first step, deciding what studies, eliminating studies that are not useful for review or to draw scientific conclusions. And everything I'm talking about is posted on FDA's website. It's in their guidance document, the Evidence-Based Review System for the Scientific Evaluation of Health Claims. I highly recommend people review this document because it lays it out. And I'm not going to go into a lot of detail, but it tells people, it gives the roadmap. So then the first question, what studies are useful? And FDA has decided that certain studies are not suitable for its review. Review articles, meta-analysis, book chapters, abstracts, animal studies, in vitro studies, studies that do not pertain to the substance or the disease. Those all may be fine studies in that they provide useful data, background data, understanding of mechanism. But to actually get to a claim, you have to have human studies that evaluate the substance-disease relationship. And those can be intervention studies or observation studies. Now, the next few slides, I'm just going to go through the kinds of questions FDA looks at. I'm not going to get into the detail because we just don't have the time to do that. But again, it's all in that document. So were the subjects healthy or did they have a disease? These are not about treating disease. Was the disease claim actually measured as a primary endpoint? Was an appropriate control group used? Was an independent role of the substance in reducing risk measured? Were there relevant differences between the control and treatment at baseline, making it difficult to look at differences in treatment? What statistical analysis was used? Was it appropriate? What type of biomarker was used? FDA only recognizes certain biomarkers as validated surrogate endpoints for disease. How long was the study conducted? Where were the studies conducted? What methods were used to estimate intake of the substance? That's often a weakness in many studies. In observational studies, what type of information was collected? And also in observational studies, was the substance a food or a food component? We often find that the substance in the study was actually a food, but people want to make the claim about a food component, and usually you can't get there from here. So going through that analysis, the scientists at FDA then, they have examples of where there are fatal flaws in those studies. No control. The statistics used are not relevant. Sometimes you get treatment or comparison of beginning to end rather than between treatment and control. The key confounders of risk were not controlled. A non-validated biomarker is used as the endpoint. You can't determine an independent effect from the study design. Observational data is used without any intake validation for the substance. The studies were conducted in malnourished populations and a type of malnourishment that's not relevant to the US population. Or the studies are conducted in a diseased population, and again, these are not about treating disease, they're about lowering risk for disease. So then the next step in the process, once you now have the body of data that you can look at, then asking the question of how do we assess the methodological quality, high, medium, or low? And again, these are just the questions that FDA will look at to do that. Were the studies randomized and blinded? Was a placebo provided? What were the exclusion-inclusion criteria? What information is provided on the study population? Do you know who's being studied? Was subject attrition assessment reported? Protocol compliance? Does it follow the intent to treat? Was it the actual disease or a surrogate endpoint? How was the onset of disease measured? Adjustment for co-founders, what was the dietary assessment method used, and reliability of the study design for observational data. Generally, FDA does not rely on low-quality data. It would have to be high or medium. So at that point, FDA has decided, okay, now we have the data, and it goes on to ask the question, is there credible evidence for the claim? So again, you're looking at the nature of the studies that you have, what effects were observed. You may find in that some show a beneficial effect, some show no effect, some show an adverse effect. So all of that has to be weighed. So again, you then reach the point where FDA, now when it knows what credible evidence is there, it can decide, is it significant scientific agreement, is it a qualified health claim, or can it deny the claim because there is no evidence. And this just gives an example of some of the health claims that are significant scientific evidence, such as calcium and osteoporosis, versus some of the qualified health claims, like lycopene and cancer. And again, this is where you'll find all of that information. So I want to go to my second example, and that's the development of the Dietary Guidelines for Americans. And just to remind you, the Dietary Guidelines are produced every 5 years. It's a joint effort between USDA and HHS. It is the federal policy document in nutrition, and so the federal government bases all of its nutrition outreach and education on the information that is in the Dietary Guidelines. USDA was the lead agency for the last process, and one of the things they did was propose that an evidence-based process be used. And so most relevant to this conference is this initial phase of the project where it's the Dietary Guidelines Advisory Committee reviewing the science and making a determination of whether or not there is science to support certain types of recommendations. They developed a methodology using PICO-style research questions, then having a literature search conducted and going through and grading and evaluating. FDA, or the dietary guideline process has, they've used a set of grading criteria, and all of that then is available on their website, the library of data that is available to support what recommendations are developed from the dietary guidelines. And I think this is a process that will be very useful going forward. And then the last example I wanted to give was to just highlight some of the work that WHO is doing on development of guidelines and standards. In 2010, WHO started an expert guidance advisory group referred to as NUGAG. Don't ask me where the name came from. There are two subcommittees, Nutrition, Action, Diet, and Health, and these subcommittees then rely on systematic reviews to make recommendations to WHO. And those systematic reviews are conducted using what's referred to as the grade process. Grading of recommendations, assessment, development, and evaluation. There's a series of papers on the grade process that has been published in the Journal of Clinical Epidemiology. The subcommittee that I'm on, the Diet and Health one, is looking at these grade reports, and then the goal is eventually to update the WHO Report 916. And some of the documents that have come out relevant to this recently have been guidelines from WHO on sodium and potassium, but then in the BMJ there are two publications, one on dietary sugars and body weight, the other on reducing total fat intake on body weight, showing the systematic review that was used, and then those documents go to the subcommittees to determine what recommendations they will make to WHO. So, John, don't panic. That was my last slide. So again, my objective was to illustrate some ways that science is used in decision-making and what kinds of information is most useful. And so I hope I was able to capture some of that from those examples. Thank you.